Good evening, everyone. Thank you so much for joining us tonight for the fourth session of Mini Medical School. My name is Katie Vickery, and I'm a program director here at the UAB School of Medicine, and I will be moderating tonight's session. We'll begin with opening remarks from Dr. Selwyn Vickers, and then we'll hear from our panelists. We'll have 15 minutes of Q&A time after we've heard from everyone. And I have collected the pre-submitted Q&A questions, and we will get to as many as possible. And we'll also get to the ones submitted in the Q&A feature on the bottom of your screen. Thank you again for joining us, and I'm pleased to introduce to you Dr. Selwyn Vickers, Dean of the School of Medicine. Dr. Vickers.
Thank you, Katie. Welcome to everyone. I'm Selwyn Vickers, the Dean of the School of Medicine at UAB, and we're excited to welcome you to our fourth session of a mini medical school. The goal of our mini medical school really is to expose you to some of the relevant topics that are going on in the world from experts who are recognized not only in Birmingham, but across our country and internationally for their science and their outstanding clinical care. These individuals we interact with on a daily basis, and we want to take the opportunity to expose them to our community through short presentations that will give you insight to some challenging illnesses that we face in America and the world. Now, all of us have participated in the past few sessions. We've talked about the pandemic that we're experiencing and the challenges of the numbers of individuals who are suffering from COVID or who've gotten infected. One of the areas of the next looming challenge of disease burden for our country really sits in the area of memory disorder and Alzheimer's disease. Some estimates that there are nearly 400,000 to 500,000 people annually who will have some memory loss. Maybe not significant or clinically relevant, but that process is going on. So we thought we would assemble a group of individuals who could help speak to us about that topic. Before I introduce them, though, I want to introduce the committee who have worked hard to put this together. Katie, thank you. So thanks to Dr. Sherry Cannon, who's here tonight, who's the chair of radiology, and we have two of her faculty speaking, Dr. McConaughey and Dr. Lappy, but Dr. Herb Chin, our chair of surgery, Dr. Jeannie Marazzo, who's our director of the infectious disease, our professor of emergency medicine and one of our vice presidents for the hospital, Sarah Nafsinger, who has been essentially our vaccine and testing czar for Alabama in the central region as well as for UAB. And Dr. Mike Sagg, who's become in many ways the COVID disease expert for the nation. We thank them for the hard work that they've done in putting together this team. Next slide. So our speakers tonight are really outstanding physician scientists who, as I mentioned, are really known globally as well as nationally for the work that they do from their research specialties and the clinical care that they provide. First is Dr. Erik Roberson, who's professor of neurology and director of the Center of Neurodegeneration and Experimental Therapeutics, who also in practice heads our Alzheimer's Center, a recent award that puts us in a fairly elite category of individual institutions that have multiple centers around neurological disorders, including movement and memory. Dr. Susan Lappy and Jonathan McConaughey came together from WashU, and they are a really compelling team that have grown our capacity to image through molecular imaging and developing of radioisotopes to image the brain and diseases in the brain that will help us hopefully have early detection of people with memory disorders, as well as movement disorders and cancers. And Dr. David Geldmacher, who is our director of the Division of Memory Disorders, an individual who has more patients than he can see in a lifetime who need to get in to see him because of this impending problem. We thank each of them for being here. We look forward to what they will share with us and to the questions that we'll answer afterwards. And I will turn it over to Dr. Erik Roberson.
Thank you, Dr. Vickers. We are really delighted this evening to have a chance to share what I think are some of the really exciting advances in the field of Alzheimer's disease over the last few years. So just to give you a kind of a sense of where we're going tonight, before we get to the question and answer period, these are the topics that we wanted to hit on. I'm going to talk about these first two, give you a brief introduction to Alzheimer's disease, what causes it, how it's diagnosed, and then talk about this newly funded Alzheimer's Disease Research Center that Dr. Vickers just mentioned. Then Dr. McConaughey and Dr. Lappy will talk about PET imaging in Alzheimer's disease. And then Dr. Geldmacher will talk about the shifting landscape of treating Alzheimer's disease and our exciting transformation of our memory disorders clinic into a state-of-the-art brain aging and memory clinic. But I think this needs to start with really defining what Alzheimer's disease is, right? So a good definition would be a degenerative dementia with plaques and tangles. So let's break that down a little bit. Degenerative, of course, just means that there is degeneration in the brain. There is a loss of brain cells that is the underlying cause of the disease. But let's dive in a little bit more on dementia and plaques and tangles. And dementia, as it contrasts, what's the difference between dementia and Alzheimer's disease? So it may help just kind of think through the natural history of someone who might develop Alzheimer's disease. Of course, they go through the majority of their life being completely normal, having no cognitive problems, but then at some point begin to develop some kind of impairment, mild at first, initially probably just more of an annoyance, gradually becoming more severe, and at some point beginning to get in the way of some of their day-to-day activities, which we refer to as functional impairment. And that idea of having cognitive impairment that is sufficient to produce some functional impairment is what we call dementia. And that's really any condition that has cognitive impairment severe enough to lead to impairment in day-to-day activities. That's what we refer to as dementia. And of course, in real life, the lines here are not quite so stark, and a lot of what we spend our time in clinic is determining if or when someone has crossed one or both of these lines. But the important point is that dementia is not a specific disease, and it can be caused by almost anything that can cause cognitive impairment of a significant nature that leads to also to functional impairment. So that could be a degenerative disease like Alzheimer's disease, but it could also be a stroke, it could be alcoholism, it could be head injury, it could be any of a number of different causes. Alzheimer's disease, on the other hand, is a specific disease. And the hallmark of Alzheimer's disease that makes it uniquely Alzheimer's disease are these plaques and tangles in the brain. These are microscopic lesions. And the important point there is that anytime you have plaques and tangles, you would meet the criteria for a diagnosis of this disease. And it doesn't have to be dementia. That can happen in this milder stage of the disease. And even as we're going to talk about in a little bit, even into these stages that are asymptomatic. I'll come back to that in just a moment. So what are these plaques and tangles? These really date back all the way to Dr. Alzheimer and the first case of Alzheimer's disease. So Dr. Alzheimer saw this patient, Augusta Dieter, in Frankfurt, Germany, around the turn of the last century. She was around age 50, had developed some memory loss, some language problems, some delusions and other psychiatric symptoms. And he cared for her, followed her for several years. And then when she died in 1906, he also did the autopsy. And this is what he found in her brain. All of the dark brown staining here on this microscope slide is abnormal. And we can divide this up into the plaques, which are circled here in red. And these are in the space outside of the neurons, between the neurons, in that we'll call the extracellular space. And then the tangles, circled in blue, which are filling up the brain cells or neurons, and thus take on the shape of a neuron. Now, it took another 80 years before we had the technology to know what these plaques and tangles were made of. But by the mid-80s, we knew the answer, and that was that plaques are made of a protein called amyloid beta, or A beta is what we normally call it. And tangles are made of a protein called tau. And these are two important proteins, A beta and tau, that we're going to refer to throughout the talk today. They've become important biomarkers for diagnosing Alzheimer's disease. And in the case of A beta, have become a drug target for the most newly approved drug for Alzheimer's disease. So what causes Alzheimer's disease? I'm going to hit on three key features: aging, genetics, and A beta. First of all, aging, which is the strongest risk factor for Alzheimer's disease. The biggest driver of the increase in Alzheimer's disease cases in the United States is the increase in life expectancy, which is really quite remarkable. So you look back 140 years, and average life expectancy was under 40 years. That has now doubled to almost 80 years today. And the result is we've gone from having almost nobody in the United States living past the age of 65 in 1900 to now having 54 million such people. And that's going to almost double again to nearly 100 million people living past the age of 65 by 2060. When you combine that with the fact that Alzheimer's disease is an age-associated disease, so you see the prevalence in the 60s, in the 70s, in the 80s, and in the 90s, you see we just have more people who are living into these ages at which Alzheimer's disease becomes very common. And that's really what's driving the Alzheimer's disease epidemic. Genetics is also important. There have been on the order of 40 or so genes that have now been strongly linked to Alzheimer's disease, but they do so in very different ways. And here we're separating the genes by two factors. One is how much they increase risk. If you inherit a variant in that gene, does it give you nearly certain risk of Alzheimer's disease or just a slight increase in risk? And the other is how common are they? Some are very rare, found in very few people, and others can occur in almost half of the population. So these genes down here, like the BIN1 gene, are quite common. Almost half of people carry a variant in BIN1, but those variants increase risk of Alzheimer's disease only slightly, maybe 10% higher than normal. And then there's these genes up here at the other end of the spectrum, which are very rare. Very few people have these variants in the genes. But if you do inherit a mutation in one of these genes, you are almost certain to get Alzheimer's disease, and it's probably going to be an early onset case of disease, starting maybe as early as in your 40s. And then there's genes like, perhaps one of the most important ones are kind of in this middle ground. So the ApoE gene is both somewhat common, present in about 10 to 15% of the population, but it also carries a moderate to high risk of the disease. And so we have all of these different genes that can be considered as contributing to Alzheimer's disease. Finally, as a cause of Alzheimer's disease, A beta, the main that component of the plaques. This idea that A beta is the primary cause of Alzheimer's disease is called the amyloid hypothesis, and there's a variety of evidence for it. Some of it is genetic. So if we go back to look at these three genes that I showed you up here, all three of these genes that, although they're rare, when you inherit a mutation, they will cause the disease. All three of these genes drive the production of A beta. And if you inherit a mutation in these genes, it makes more A beta in the brain, and it makes the more toxic form of A beta in the brain. So, there's this strong genetic evidence. There's also evidence from animal models. If we express high levels of A beta in the brain, that causes not only plaques in the brains of these mice, but it causes memory deficits, it causes inflammation, it causes neuron loss and other features of Alzheimer's disease. And then maybe most importantly is the clinical trial evidence. If you take drugs, if you manipulate A beta, if you reduce A beta, does that have a beneficial effect? Which is what you would predict if it were an important cause of the disease. And we now are beginning to get some data from clinical trials of drugs that target A beta. And I'll leave that discussion for Dr. Geldmacher in just a few minutes. How do we diagnose Alzheimer's disease? This has been one of the most rapidly advancing aspects of our field. And we're really seeing a greater shift toward the use of biomarkers. I think that's the most important message here. We're shifting from Alzheimer's disease being a clinical diagnosis that is based primarily on a history. So if we would see a patient and get a history that there's some age-associated cognitive change that started gradually, that is being slowly progressive, gradually getting worse over the years, and we rule out some of the obvious other causes of cognitive impairment, that would be sufficient in the past and sort of up until the present day for a diagnosis of probable Alzheimer's disease. The change and where we're going to and getting to, almost today, if not in the very near future, is a reliance more on biomarkers. So with this clinical diagnosis, although I said at the beginning that Alzheimer's disease is defined by plaques and tangles, a clinical diagnosis has no knowledge of whether there are plaques and tangles in the brain. A biomarker diagnosis relies on measures that do give indication of whether there's amyloid plaques, tau tangles, or other aspects of neurodegeneration that are going on. So what are these biomarkers? Initially, spinal fluid was the best biomarker. Spinal fluid is the fluid that actually bathes the brain. We can obtain that from a lumbar puncture. And it has the advantage of actually giving an insight into what's going on in the central nervous system. The disadvantage, of course, is that most people don't want to have a lumbar puncture to get a sample of this fluid. So a lot of work went into developing blood-based biomarkers. The problem is that A beta and tau and these other markers that are normally in the brain are present at much lower levels in the blood. And so it required the development of much more sensitive assays to be able to get these blood tests. But we're now getting to that point, and I think in the very near future, we're likely to have clinically available blood testing that will give us much the same information that spinal fluid testing would give. And then, of course, we also have imaging-based tests, both MRI and PET scans, and you're going to hear more about that in just a second from Dr. Lappy and Dr. McConaughey. The important thing that biomarkers have taught us is that the plaques and the tangles actually develop before there are any symptoms. So here we're kind of mapping onto that normal to mild kind of impairment to dementia scale that I showed you at the beginning. Here, so purple line is the beginning of memory symptoms, green line is the beginning of functional impairment. And the important point here is that what we've learned over the years is that amyloid changes, the plaques, as you see with A beta biomarkers in red, or the tangles with the tau biomarkers in blue, these are actually happening even before the onset of symptoms in this asymptomatic stage of the disease. And while that might sound a little bit scary, that you can have plaques and tangles even in those of us who are not having any symptoms of the disease, it's actually quite a good thing that we are able to diagnose this early, because when we do discover effective treatments that block the effects of this amyloid and beta, we can deploy those treatments at these early stages of disease, and hopefully we'll be able to block the disease before it really starts to produce the more severe symptoms, which are going to be difficult to reverse. So before I turn it over to discuss the imaging a little more, I just want to mention our new Alzheimer's Disease Research Center, which is focused on Deep South disparities in Alzheimer's disease. And the rationale for this is driven by data like this that looks at the risk of Alzheimer's disease based on the state in which someone is born. And what you see here, darker colors mean higher risk of Alzheimer's disease. On the left is data for blacks, on the right, data for whites. And in both groups, you see that some of the highest groups for risk of Alzheimer's disease is in the Deep South. So there's any number of potential reasons for this. For example, many of the risk factors that we know are associated with Alzheimer's disease are more common in the Deep South. African Americans are at higher risk of Alzheimer's disease, and the highest population density of African Americans is in the South. Vascular disease in the brain, which we can look at stroke deaths as a proxy measure for. Again, we're kind of right across here in the stroke belt. It's the diabetes belt, it's the obesity belt. All of these are risk factors that are endemic in our region that could be aspects of contributing to Alzheimer's disease, but there are others. And so we started what we call the Brain Aging and Memory in the South study, or the BAMS study, as a way to start to dissect this by recruiting volunteers who are representative of the Deep South, both racially and in terms of these vascular and metabolic risk factors and other aspects of living in the South, and to have them come in for annual testing, medical, neurological, cognitive tests, look at social determinants of health, which we know can contribute to Alzheimer's disease, look at imaging, both structural imaging with MRI and biomarkers for amyloid and tau, the blood and CSF biomarkers that I mentioned, looking at some of the genetic risk factors that I mentioned, and hopefully, eventually, at the end of life, having a chance to look at their brains if they are willing to participate in brain donation. So we think that this is going to be an important study, and we're really excited that, as Dr. Vickers mentioned, we have been funded now by the NIH to do this. The NIH funds an elite suite of about 30 centers across the country to do Alzheimer's disease research like this, to recruit a cohort that targets specific questions for that center. And we are now an exploratory center, which is the way that you get into this network, a starter grant for these first 3 years that will put us in a position in 2023 to apply to continue as part of this network. So an exciting recognition of the research that we're doing, and we're really excited to be part of this group. So now let me stop here, and I will turn it over to Jonathan and Susie to tell you more about our imaging biomarkers.
Great, thank you so much, Dr. Roberson. So now I'm Suzanne Lappy. I'm a chemist by training, and I'm going to talk a little bit about how we make molecular imaging agents, and then I'll pass it over to Dr. McConaughey, who will talk a little bit about the clinical imaging trials. Next slide, please. So we do molecular imaging by creation of radiopharmaceuticals. So these radiopharmaceuticals is simply a drug that's labeled with a radioactive isotope or a radionuclide that can be used to image a biological process or to treat a disease. So the overall chemical structure of the drug determines the biological properties, where it's going to go, how it will bind to a certain biomarker, such as Dr. Roberson mentioned. And the radionuclide or the radioactive agent that we attach to the drug determines the imaging or therapeutic properties. So you can see a little schematic here. We have our radioactive isotope. You can think of it like a beacon that tells us where the drug is going to go. And we make these drugs in what we call high specific activity. So this means that we can see very, very, very small amounts of these drugs. So by using these radioactive techniques, we can inject a mass of a radiopharmaceutical that's smaller than the grain of salt and actually get a clear image of the biological structures and these biomarkers in the brain. Next slide, please. So for example, we can radio label D-glucose, which is a sugar molecule, with fluorine 18, which is our radioactive isotope. And so we can get a tracer that basically measures glucose uptake. And we use these tracers commonly to look at neurodegeneration and also cancer studies as well. Next slide, please. So I mentioned that I'm the director of the Cyclotron facility. So what does the cyclotron have to do with imaging? Well, the cyclotron is actually how we make those radioactive isotopes. So the UAB cyclotron is a particle accelerator that actually accelerates protons to 3/4 of the speed of light. Those protons hit a target. This can be gas, solid, or liquid. And that's how we induce a nuclear reaction to make those different radioisotopes. We can take those radioisotopes, then we label the drug, and then we can proceed with our imaging studies. Next slide, please. So for example, if we're interested in making drugs that we can use to image biomarkers that are prevalent in Alzheimer's disease, we can use agents that we know bind to, for example, A-beta. So I'm showing here, this is thioflavin T that we can tag with our radioactive isotope, carbon-11, and we can make a compound called carbon-11 PIB. And so carbon-11 PIB binds to these A-beta plaques in the brain. And so we can use this to get an image of the density of the A-beta in the patient. And carbon-11 PIB at UAB and elsewhere has been used extensively in studies for amyloid plaque imaging. And then you can see the green slide here, which is very similar to the slide that Dr. Roberson showed, showing that we can use the non-radioactive version of this agent to stain slides to look for A-beta as well. Next slide, please. So our imaging facility and the radiopharmaceutical production facility is located in the Wallace Tumor Institute, so right in the middle of campus. And we have our PET MRI so that we can get images of the PET signal, and we can actually co-register it with MRI. So we can get images that show us the density of A-beta as well as the structure changes in the brain. We also have PET CTs that we can do similar studies with. And then down below, I show a photograph of our TR24 cyclotron, which is where we make all of our radioactive compounds that we use for imaging. Next slide, please. So the cyclotron facility and the radiochemistry laboratory, we do the isotope production with the cyclotron and develop the chemistry for new imaging agents. We can then characterize new radiopharmaceuticals, and then we translate them into clinical trials. So we can actually enable new clinical trials with new biomarkers that are important to Dr. Roberson and other treating physicians. We also support many ongoing existing clinical trials, and then we produce PET tracers for routine clinical use. Next slide, please. And now I'm going to pass it over to Dr. McConaughey, who will talk a little bit more about how we use these radiopharmaceuticals to better understand Alzheimer's disease.
Thank you, Susie. Great introduction of the Cyclotron facility and its production capability. So yes, we're going to shift gears a bit and talk about how we use PET tracers in patients being evaluated for cognitive impairment and Alzheimer's disease. So this page shows a list of PET tracers made for human use in the UAB Cyclotron facility. Those in blue are primarily for brain imaging, and you can see amyloid and tau agents are on our list. And we'll focus on those mostly in a clinical context, but we're lucky to have access to a range of compounds for investigational and research studies as well. Next slide, please. So in order to form images from PET tracers, we use PET cameras, and these detect the radiation. And in a simple sense, we're looking at the location and the concentration of a radioactive drug. In this case, in images in the brain, looking at beta amyloid in the cortex. We can use PET MRI or PET CT systems, and we're lucky to have PET MRI, which allows us to acquire PET images and MR images simultaneously, which reduces the burden on our patients and our research participants. We're one of the few centers in the Southeast and the only in Alabama to have this, in large part through a philanthropic gift from the Stevens family. If we could have the next slide. So nuclear medicine studies like PET exams differ depending on the type of tracer and type of study, but there's some common features. So for some tracers, patients need to get prepared for the study, and that typically means not eating any calories for about 4 to 6 hours before the study. Patients and research subjects arrive at the PET center, they check in, we review the study. When it's time for the study, we inject the tracer intravenously in the same way you might get other medications administered. And often we have an uptake time in between the time of injection and the time of imaging. And so we have rooms for patients and research subjects where they can spend either 20 minutes or up to about an hour before we're ready for imaging. And that gives time for the PET tracer to get to where it needs to go, as well as to clear from normal structures so we can form a good image. Patients then undergo imaging, which can be as short as 5 to 10 minutes for some routine clinical studies of the brain, up to 60 minutes to 90 minutes for some research studies. We then get an image, which, if it's a clinical study, an imaging physician like myself will interpret it and issue a report. If it's a research study, we may do other kinds of analysis. And in the case of clinical studies, a report is generated, which is available to the referring physician, who's typically the one who discusses the results with the patient and family, because in addition to knowing what the imaging showed, typically patients want to know, well, what's the next step based on the imaging? Next slide. So as Erik mentioned, it's important to understand that different biomarkers become abnormal in Alzheimer's disease, depending on where a patient is as the disease progresses. And that's important for understanding what type of imaging biomarker to use for a research study or a clinical study. So if we want the earliest possible detection of the disease, we want to use amyloid PET. But we know that it can be 1 to 2 decades before a patient with a positive amyloid scan may have clinical symptoms. And so if we want to know whether a patient is likely to progress in the near future, other imaging like tau imaging or FDG PET to look at neuronal injury causing changes in brain glucose metabolism, or measurements of MR brain volumes can give us a better sense of how close a patient is and how high their near-term risk is for converting to clinical impairment or dementia. And so it's good to have access to a range of biomarkers so we can accurately stage a patient as they progress through the pathology of Alzheimer's disease. Next slide. So we have a number of tools available, and we've mentioned these. Beta amyloid and tau are relatively specific to Alzheimer's disease, although not completely specific. Glucose metabolism with FDG is another important tool for evaluation of patients with possible Alzheimer's disease. And while we're not going to discuss it here, we can also image something called the dopaminergic system, very important in Parkinson's disease, and important in some other causes of dementia that can resemble Alzheimer's disease. And these are just the FDA approved clinically available PET tracers that we can use and issue reports for. There are a greater number of tracers that are under investigation and part of research studies. One of the limitations for clinical beta amyloid and tau is that Medicare doesn't currently reimburse these studies. That's starting to change with some private insurers, and I'm hopeful that in the near future this may change, but that has limited access because these studies are quite expensive if patients have to pay out of pocket. Next slide. So this is an example of two different FDG PET studies done in patients. We're looking at the brain as if from the surface and the side. Areas of blue and purple are areas where there's decreased glucose metabolism compared to what a healthy brain should look like. So in the top row, we see an Alzheimer's disease pattern where the areas of decreased glucose use are more in the back of the brain, or a posterior parieto-temporal distribution. On the bottom row, we see what is a frontotemporal dementia pattern, where the front of the brain is more affected. So the frontal cortex and the anterior temporal cortex are more affected. And so these patterns with FDG can help us make an accurate diagnosis, but many causes of brain injury, neurodegeneration or other non-neurodegenerative causes can decrease glucose metabolism. So while FDG is useful, it doesn't show the specific molecular patterns and molecular abnormalities that are characteristic of Alzheimer's disease. So next slide. So what previously required autopsy after death is now able to be done while patients are alive. So again, we see these plaques and tangles that are the pathological hallmarks of Alzheimer's disease. But next slide. We can now see these with imaging. And so we can determine if a patient has abnormal amyloid in the brain and abnormal tau in the brain. And so we're moving to a point where if we can see amyloid and tau in the living brain, we can, before a patient dies, make the diagnosis of Alzheimer's disease and hopefully treat that. You know, this is an area of very active and some controversy, but I think the ability to do this while patients are alive is very important for research, and I think it's going to become increasingly important in routine clinical care. Next slide. So we're getting to a point where we can stage Alzheimer's disease from a patient who has no biomarkers of Alzheimer's disease, negative for beta amyloid, negative for tau, to patients who have evidence of Alzheimer's disease pathology, but are relatively early in the progression from start of pathology to onset of actual neurodegeneration. So an amyloid positive but tau negative patient, to patients who have both biomarkers, amyloid and tau positivity, and are, if they aren't already symptomatic, are at high risk for being symptomatic from Alzheimer's disease in the near future. Next slide. So I'd like to finish up with a case. This is a 64-year-old woman. She presented with mild stage dementia, and she had prominent language difficulties, such as finding the right word in a conversation. And after assessment by memory specialists, the considerations were Alzheimer's disease versus frontotemporal dementia. And they have very different molecular pathologies. And if we're considering anti-amyloid therapy, Alzheimer's disease is someone with Alzheimer's disease is a potential candidate for anti-amyloid therapy, whereas a patient with frontotemporal dementia is not. So this patient had a clinical amyloid PET-MR performed to help distinguish these two possible causes of her dementia. Next slide. And what gets me excited about imaging is that with PET-MR, we can actually do a pretty comprehensive evaluation in about a 20-minute scan. So in this patient, we see that there's abnormal amyloid in the brain, so they're amyloid positive. This makes Alzheimer's disease more likely than frontotemporal dementia. We can use the MRI to define brain regions to do quantification, so we can measure the relative amounts of abnormal amyloid in various brain regions using the MR as a template. And then we can look at the MR itself for evidence of neuronal injury and neurodegeneration. Here we can see that the temporal lobe is lower than expected in terms of volume indicating injury. And you can see this loss of volume on the left compared to the right on the MR images themselves, with sparing of other brain regions. And this fits with the patient's presentation because the left temporal lobe and the cortical regions are important in language. So here we provide strong imaging biomarker evidence that this patient has Alzheimer's disease rather than frontotemporal dementia, and provide imaging-based staging along the development of Alzheimer's disease pathology. So thank you for your attention, and I will now turn it over to Dr. Geldmacher.
Thank you, John. It's a pleasure to be able to speak to this audience tonight, and I'd like to talk a little bit about where we are in the world of addressing the plaques and tangles from the perspective of therapy, and also how we address this now with our clinical services. Next slide, please. So Alzheimer's disease is part of the silver tsunami, and as Dr. Roberson has already pointed out, our population is aging, and with increased numbers of older adults, we're going to see increased numbers of people with Alzheimer's disease. Next slide. So currently in the United States, we have about 6 million people with Alzheimer's disease and related disorders, that is dementia due to Alzheimer's disease. As Dr. Vickers has mentioned, almost 500,000 new diagnoses a year. This is an incredible number today, but by 2050, we expect that number to almost triple, up to almost 14 million cases in care at that time. During the same time, we do not expect the number of neurologists or other experts in the field to increase at the same pace. There just isn't that growth capacity. So we need to think about new ways of caring for people with Alzheimer's disease and related disorder. Next slide. Just to put this in perspective, we used to talk about the AIDS epidemic, but it's important to recognize that by the end of 2017, the total number of all people ever diagnosed with AIDS was about 1.3 million. Or less than a quarter of the number of people with Alzheimer's disease today, and about a tenth of the number of people with Alzheimer's disease we expect to see over the next 30 years. Right? Just orders of magnitude different. Next slide, please. In Alabama, we're going to face these specific problems. All of our age bands in the state are relatively stable, and they're anticipated to stay about the same proportion of the population through 2040. But our oldest adults, those age 65 and older, are expected to grow by 62% by 2040. So those numbers of increasing numbers of Alzheimer's disease nationwide are going to be reflected here in our own state. Next slide. So the good news is we have just, as of this summer, entered into a new era in treatment for Alzheimer's disease. So the drug with the generic name aducanumab, the brand name Aduhelm, was approved by the FDA on June 7th for monthly IV infusions. There are 2 other similar drugs that have been submitted for approval. The approval of this drug was based on its ability to remove amyloid plaques from the brain. And the graph on the right of the slide shows that over the course of a year and a half of treatment with the medication at high dose, that the plaques essentially were removed from the brain, and those individuals with placebo therapy during that same time, not receiving active drug, basically had a stable amount of amyloid in the brain. Now, the fact that the approval was based on reducing a biomarker, like the brain amyloid levels, rather than clinical effectiveness, has been a source of controversy in the field, and we haven't completely settled this out. But this pathway, approving a drug on its biomarker activity, is common in cancer, and many of our most recent cancer drugs, in fact, move biomarkers without necessarily being tested to alter the course of the illness. Now, one thing about this is that this drug, the aducanumab, is recommended only for treatment of mild cases of mild cognitive impairment or mild dementia. And in that ideal state, we may be able to slow progression of the illness by 20 to 25%. So if people are minimally impaired and able to maintain independence for a longer period of time, we count that as a success for this kind of therapy. Now, like any medication, there's always a risk, there's always a concern for side effects, and the safety concerns for aducanumab are significant. About 1 in 4 people who received the drug had episodes of brain bleeding. Most of those were asymptomatic. About 40% of people developed brain swelling. And these are direct results of the way the drug works in the brain, pulling amyloid out of the brain tissue, pulling amyloid out of the blood vessels, both increase the risk for these side effects. But as stated, the majority of these events are mild or completely asymptomatic. And looking at risk versus benefit, I think there's a real chance for benefit for a lot of people from this kind of therapy. Next slide, please. As I mentioned, because of the risk for side effects, we do have to pay careful attention. So in the clinical trials and in the recommendations for clinical therapy, we need to establish ahead of time whether there's been any brain bleeding. And if symptoms emerge, we would need to get an MRI to look for swelling or bleeding. And then MRI again at 6 months and 12 months into therapy. During this time, the dose of the medication at monthly intervals would be increased. And we finally reached that maximum dose, or what we believe to be the maximally effective dose, at 7 months into therapy. So it does take a while to build this up. We at UAB were a site in the clinical trials. And so our team does have experience with administering this medicine and monitoring for the side effects, which puts us in a good position to be a treatment center as time moves forward. Next slide, please. One problem with this, though, is if we look at people with mild memory impairments and open the door to therapies for them, we're going to see a dramatic increase in the number of people seeking care for the risk for Alzheimer's disease and for treatment of mild stages. And the RAND Corporation did some simulation analyses of these several years ago. And their calculations suggest that with the increase in demand, that patients would have to wait an average of more than a year and a half to receive treatment with these kinds of medications. And that because of that long waiting time, 2 million or more people would be predicted to develop Alzheimer's dementia between 2020 and 2040, while on the waiting list to see a specialist. And a specialist, as it was defined in these studies, was any neurologist, any geriatrician, any geriatric psychiatrist. And so a very broad definition of specialists with these long delays. So we need to have a plan for addressing this kind of increase in demand as these medicines move forward into the clinical space. Slide, please. So we need to practice dementia care differently. And simply adding more neurologists won't meet the demand. We can't produce neurologists as quickly as our population will produce people with Alzheimer's disease and mild cognitive impairment. So we can't just do more of what we've already been doing, but we have to change system-wide throughout the UAB health system how we approach dementia care. So we need to optimize technologies for cognitive screening and testing outside of clinic, computer-based testing at home, for instance, to assess whether memory performance is normal for age. And our Alzheimer's Disease Research Center is conducting this exact kind of testing and research right now. We need to empower and equip our primary care providers for better dementia care. Right now, dementia and Alzheimer's disease are daunting propositions for an internist or a family medicine specialist without those years of training in neurology and in cognitive performance. We need to do a better job of training our physicians, as well as our advanced practice providers, like nurse practitioners and physician assistants. We are cooperating with the nursing school now to develop expertise in advanced practice providers for dementia care for placement into community hospitals and primary care practices and the like. We also have to do a better job with other causes of memory loss, things like depression and sleep impairment and pain. We've already taken the steps to expand our social work and case management programs for people with dementia for the purpose of caregiver support. And all of these are useful and necessary for optimizing dementia care. Next slide, please. One thing we want to do is to think about dementia and its impact on the family, because most people with dementia will receive their care in a family setting. So we want to enhance our interdisciplinary focus, looking at the various roles of different professionals, physicians, nurses, nurse practitioners, social workers, therapists, and the like. We want to emphasize the quality of life of the person with the cognitive impairment, as well as the quality of life of the families that supports them. And therefore, we need to understand and be able to react to variability in family care needs. Different families have different financial and emotional resources, and we need to tune our care to that. This is moving beyond the biology of the disease and into the social needs of the people who face the disorder. Next slide, please. So what are the benefits to interdisciplinary dementia care? We know that people want to see an expert physician, but sometimes a physician isn't the person in the right position to provide the best care. We have a team of professionals in interdisciplinary. Next slide, please. And research has shown us that when a team approach is taken, a disease management approach with multiple professionals, that care improves. We see better adherence to treatment guidelines, almost doubling the adherence to treatment guidelines. Quality of care over 21 and 23 guidelines was improved with this interdisciplinary approach. We have people better able to use community services and resources, and we can improve the quality of the life of people affected by the disease and by their family members. Next slide. We know that when care is effectively delivered, it makes a difference. One of the things that many people with Alzheimer's disease and their families want to avoid is nursing home placement. And we know that intensive social interventions can delay or reduce nursing home placement, as well as persistent medical interventions, even with our older therapies, like the cholinesterase inhibitor drugs that have been around for 25 years now. So effective, persistent care provides better outcomes. Next slide. So in our revised interdisciplinary memory clinic, what we're calling the Brain Aging and Memory Clinic, our goals are to improve timely access and quality of care for patients. People, before we made these changes, were waiting up to a year or more to see our physicians, and we can accelerate that process now. As I mentioned, we want to support training for new expert clinicians in dementia care through collaboration with our School of Medicine and our students here, our Department of Neurology, as well as with the School of Nursing. And we want to support our primary care colleagues in initiating care paths so people can get a pathway toward better memory care started even before seeing a specialist. So we don't have the ability to increase our net number of neurologists yet. We're certainly working in that direction, but that's a long-term plan. But in the short term, we have doubled our nurse practitioner cohort to 4 nurse practitioners. We have 3 nurses who operate in the clinic, 2 case managers, 2 social workers, a pharmacist, and pharmacy technicians. And across this scope of expertise, we think we can provide better care, and we're already seeing better access to our service. So let me wrap up our formal portion of the presentation with just some summary points. As Dr. Roberson has noted, Alzheimer's disease is biologically complex, and there are genetic and lifestyle and general health conditions all contribute to the risk and expression of Alzheimer's disease. It's a public health challenge. The numbers are going to continue to increase for 30 more years, and this means a continued increase in our need to provide better and high-quality services, as well as earlier interventions to prevent the disease. Fortunately, those early interventions are being facilitated by biomarker processes like our Advanced Imaging Center, and I think this will have an increasing role over the next several years. We now have therapies for the first time to address the underlying pathology of the disease, with the first of the anti-amyloid therapies coming out this year. And soon, I expect we'll see more anti-amyloid therapies, as well as anti-tau therapies, and completely novel ways of addressing the illness that we haven't even put into clinical trials testing yet. But through our laboratories at the Alzheimer's Disease Research Center, through the Center for Neurodegeneration, those new pathways for therapy are already being explored. And finally, for what we're doing today, we can improve the quality of care for our folks, improve the outcomes through interdisciplinary, multiple professions, and the delivery of care for our people with mild cognitive impairment and dementia due to Alzheimer's disease. So I think at this point, I can turn things back over to our moderator for questions and answers.
Yes, we are about to go into question and answer. I did want to let y'all know that you can follow UAB's Department of Neurology on Twitter at UAB_neurology, and their Alzheimer's account, which is at UAB_Alzheimers. Dr. Vickers, were you going to say something?
No, I was going to just say that I thank each of the speakers for their talk. I thought it was outstanding for all of them. but maybe we can start the Q&A.
Perfect. Well, I will start with a few of the questions submitted in the chat and in the Q&A, and then I have some that were pre-submitted as well. 1 second. So how can you volunteer for the BAM study?
So you can call the Alzheimer's Disease Center, which is 934-6307. You can also look at our website, which is uab.edu/Alzheimers. And if you go to the research tab, there's a link there where you can enter your information on a form. And that also has all of our contact information, both email address and the phone number if you need it there.
And I can put those links and that information in the email that we'll send out to all the attendees with the recording of this email. So look for that tomorrow.
We're looking for people who are 55 and older, and both people who have normal memory and people who have memory impairment for that study.
Perfect. Can you discuss, any of you, the symptom differences between Alzheimer's and dementia?
I can take that. What we're talking about, and I think Dr. Roberson pointed out this very well, Alzheimer's disease is a disease of the brain, a specific set of biological processes. Dementia is a description of the severity of impairment. So someone would have dementia when they have changes in memory and thinking that interfere with your everyday function. There are dozens of diseases that can cause dementia. And that's what we do in the memory clinic, is we work up folks for those processes. We look for stroke, for vitamin deficiencies or hormone changes that might be leading to cognitive impairment and dementia. Sometimes, using things like the PET scans and other biomarkers, we can determine that Alzheimer pathology is the cause of dementia. So it's not a either or. It is dementia is the result of Alzheimer's disease, or dementia is the result of strokes.
Thank you. Does the School of Medicine have a mandate to meet this challenge? I'm assuming that means the lack of neurologists and the increase of patients. And how will the School of Medicine address the potential shortage of neurologists and increase efforts in basic sciences?
So our Department of Neurology trains 9 neurologists a year through our residency program. And I know Dr. Geldmacher and Dr. Roberson, as well as Dr. David Standard, have thought significantly about how we grow that process for our state. There is a tremendous shortage in our state alone, and we are the primary training source for new neurologists. So as it relates to what's within our power control, we're doing all we can to both increase the interest in our students to choose this as a career. And we're doing all we can within our financial means to add new training programs and slots for neurologists to be produced and for our state and for the region. I would say Dr. Geldmacher's point of, can we train enough neurologists to keep up with this? We can. We'll have to design mechanisms to be able to reach out to individuals, often through digital health, telemedicine, and through extensions of our care through other caregivers, such as nurse practitioners. But it is daunting for us, concerning, because most of the therapies right now are infusions that you have to get as an IV. They're not pills. So there are a lot of challenges we face, not only here, but across the country.
And I can follow up on a little bit more about that, about our desire to increase the number of neurologists in training. 10 years ago, about 3, maybe 5 UAB students per year chose neurology. This year, we're up to close to 20. So we've done a lot to engage our medical students as an interest in neurology and have them go off to training in other institutions as well as here to increase that net number of neurologists that we're producing.
Thank you. This is a 2-part question. The first part, what brain bleeds were noted as ASC with Aduhelm?
Okay. So the most common brain bleeding with aducanumab are what we call microhemorrhages. These are very small. They're detectable generally only by MRI scan. with tuning of the instrument to look specifically for iron deposition. As I said, the majority of those events were asymptomatic. They occur in the white matter of the disease just below the gray matter, and were in the clinical trials detected primarily by routine MRI scanning rather than in response to symptoms.
Thank you. And then the second part, is there basic advice for families asking for genetic counseling when a parent has Alzheimer's?
I can take that one. When I talked about the genetic risks for Alzheimer's disease, but really the ones that really go directly from parent to child and hit every generation are quite rare. I think it's something to talk about at a clinic visit with a physician about whether genetic testing is warranted. We don't generally do a lot of it. We do have a research protocol for early onset forms of dementia, or the more uncommon forms, to be able to look into that. In a more later onset form, the yield tends to be low. And the important thing to remember is that Alzheimer's disease is really common. And that, so it doesn't mean that everybody who gets Alzheimer's disease has a genetic cause and that's going to be handed down to their children. In fact, that sort of transmission from parent to child is relatively rare, especially if the age of onset for the disease, is in the more typical, 70s and 80s for typical Alzheimer's disease. But it's, talk about it with your physician is the answer, and have a personal discussion for given the information in a specific family about whether testing is warranted.
Thank you. Dr. Roberson, this might be another question for you. Does UAB have a program that trains the family caregivers on how to deal with dementia at home?
Yeah, actually, I'm gonna. That's actually more Dr. Geldmacher's specialty. So I'm gonna turn that one back over to him.
So we do not currently have a family training program. There are support agencies out in our community, Alzheimer's of Central Alabama, that does a lot of work with families facing Alzheimer's disease. Support groups are often a great source for that. We would like to expand into that caregiver training. Funding that sort of program is a significant challenge. It's not something that typically health insurance pays for, and the professional staffing is expensive. But yes, ideally, we would like to be able to create classroom type training for caregivers as part of our memory clinic program. That's an aspirational goal right now. But in the meantime, Alzheimer's of Central Alabama and the Alzheimer's Association are places where caregivers can earn for training and support in the caregiving role.
I will add that, Dr. Geldmacher talked about the fact that we've doubled the number of nurse practitioners in our clinic. And a lot of what our nurse practitioners are able to do is provide coaching for caregivers, in those situations about how to deal with all the day-to-day life situations that come up. So it's handled more on a sort of a coaching basis in clinic, but it is an important aspect of what, one important benefit of that team approach, and what our nurse practitioners can provide.
Thank you. Is there anything that can be done to prevent Alzheimer's?
There are several things in terms of lifestyle that we recommend that have been shown at a group level to reduce the risk of Alzheimer's disease. Probably the most important is physical exercise, combining some combination of aerobic, doing something that gets your heart rate up, going for walks or going to the gym on exercise equipment, and some weight work to build up the amount of skeletal muscle. Staying mentally active, and being engaged with other people in creative activities and things like that. Eating a healthy diet, keeping your blood pressure controlled, and getting good sleep. Those are all the different kinds of things that we kind of coach people through. These are probably effective even if you are starting to have some memory problems, as ways to slow that down, but also proven as some of the best things that all of us can and should be doing to reduce our risk of age-related cognitive decline.
Thank you. How do you take care of someone who lives alone and refuses to acknowledge their illness?
Well, there's no simple answer to that. Inability to recognize impairment is typical in Alzheimer's disease. One of the clinical characteristics that help us recognize AD. What we try to do is to make sure that we optimize the family's ability to maintain that person's safety and nutrition. They don't have to acknowledge that they're impaired, but we do want to make sure that their impairment is not something that's going to put them or their neighbors at physical risk. But these are highly individualized. There isn't a generic, this is what you do every time when someone doesn't understand that they have memory loss, and that memory loss interferes with their independence.
Thank you. Are there any medications or foods that you would recommend avoiding in young patients, 20s and 40s long-term? Artificial sweeteners, other types of drugs?
So there's no known links between medication exposure and development of Alzheimer's disease. There are medicines that people take that can interfere with cognitive abilities, and the longer you take them, the more interference they may have. Alcohol is the perhaps most prominent contributor in that equation, but medications such as narcotic pain pills, chronic anti-anxiety treatments in the Valium class of medicines, and some of the anti-allergy type medicines like diphenhydramine or Benadryl is the brand name, in chronic use increase the risk for developing dementia. So yes, there are medicines that should be avoided. Basically, those medicines that suppress brain function increase the risk for developing memory loss and dementia later on.
Thank you. And we can wrap up with 2 last questions. Are there any oral therapies in development?
Yes. So oral therapies are our holy grail, if you will. We know that in terms of cost effectiveness and ease of distribution and ease of maintenance of therapy, that we need to move in that direction. It has been a troublesome line of development, and the last set of drugs that we looked at for oral therapies to prevent the onset or progression of Alzheimer's disease actually did not work. And so we're looking at alternative pathways. Our laboratories, such as Dr. Roberson's laboratory and Dr. Prisco's laboratory, are looking at mechanisms that might be amenable to oral therapy, but those are still in the distant future.
Thank you. And does dementia affect glucose metabolism, hypoglycemia or hyperglycemia?
Dr. Roberson, did you want to take that one?
There are some links toward the way that the brain uses glucose. Dr. McConaughey showed you some images of abnormal glucose metabolism in the brain. And some people consider Alzheimer's disease to be a form of kind of brain-specific diabetes in terms of the way that the brain cells are using glucose. And we also know that diabetes in general is a risk factor for developing Alzheimer's. So there are some very complex links between glucose utilization and Alzheimer's disease.
Great, thank you so much. Dr. Vickers, I'll turn it over to you.
Thank you, Katie. Thank you again, Erik, David, Susie, as well as Jonathan. All of the work that you've done in putting this talks together and the coordinated effort to give us a tremendous overview of this challenging disease and to some degree this pending tsunami of patients who have potentially this diagnosis. I would say that would let you know that the NIH and federal government over the next year on an annual basis are putting close to 2 to 3 billion in memory and neurological research. It took those type of dollars to get significant treatments for HIV, and it will take these type of dollars to get the best and brightest individuals investigating and studying how we can treat this disease. This won't be the first time we faced a disease that we thought was incurable. We've recently just come through a set of challenges where we had no real cure or treatment. And over a short period of time, we found treatments and we found preventions. And we hope the same for this. I would say when you attend in the future, invite somebody else to sign on. They don't have to be in Alabama, they can be anywhere. And I think the information that we share can be applicable for anybody to hear. We want to make sure that people, not only in our state, but really across the country, appreciate the expertise we have at our school in UAB medicine. So I hope you enjoyed tonight and hopefully got a number of your questions answered. Please go to the websites that are mentioned. If you want to support our Alzheimer's efforts through any philanthropic gift, please visit
to go to UAB EDU Mini Medical School. And obviously, your contributions will be appreciated in expanding our capacity to continually both do research, be a leader. And as Dr. Roberson and Dr. Geldmacher showed, we're trying to actually make sure we are a beacon of care and really a bulwark against disease in the Deep South, where some of the greatest risk exist in our country. So thank you all for participating. Katie, thank you for your moderation. And thank, again, all of our speakers and our attendees who were able to sign on. We'll see you next time. Thank you all.